Julia, si quieres arrancar, estamos.
Bueno, buenas noches a todos. Y lo que les quiero pedir que por favor pongan su nombre cuando entran. Así estamos todos con nombre, después no se mezclan con las preguntas. Yo voy a empezar, lo voy a presentar a Henri Manasse, que la verdad que les voy a pedir disculpas, voy a leer porque su biografía, digamos, es tan larga, ha hecho tantas cosas que bueno, esto es largo. Bueno, quien nos va a hablar hoy fue vicepresidente ejecutivo y CEO de la Asociación de Farmacéuticos de Hospital desde 1997 a 2011, y luego de su retiro hasta el presente presta servicio como profesor y decano emérito en la Universidad de Illinois en Chicago, en el colegio, en la Escuela de Farmacia. Es profesor clínico adjunto en la Universidad AFAM de Texas, que es donde está ahora dando unas clases, así que nos va a hablar de ahí, y es en el Rangel College de Farmacia. El doctor Manasse obtuvo su título como bachiller en ciencias farmacéuticas de la Universidad de Illinois, en Medical Center, una maestría en artes, en educación, en Loyola University de Chicago, y su doctorado es administración en farmacia de la Universidad de Minnesota. En 2007 recibió el premio de Harvey A. Whitney Lecture Award, y también ha recibido títulos honorarios de varias universidades. Doctor honorario de ciencia de la Universidad de Campbell, Mercer University, Union University, Long Island University, Thomas Jefferson University, Universidad de Ciencias de Filadelfia, Touro University y la Universidad de Salamanca en España. En el año 2014, el colegio, en la Escuela de Farmacia de St. Louis le hace entrega de la medalla Henry Milton Welpley, Sesquicentennial. Es autor de diversos libros y capítulos de libros, de una extensa literatura en ciencias de la salud. Y también recibió el prestigioso premio Joseph A. Otis Award por su excepcional servicio en la FFIP, la Federación Internacional Farmacéutica, en 2015. Les pido disculpas, sigo. Previo a unirse a la Asociación de Farmacéuticos de Hospital, el doctor Manasse fue vicepresidente en Ciencias de la Salud de la University of Iowa y presidente del consejo de la misma universidad en Sistema de Salud. Y también fue vicecanciller interino en Ciencias de la Salud de la Universidad de Illinois, Chicago Medical Center. Ha tenido una variada selección de puestos académicos y administrativos como decano, profesor de administración en farmacia y como profesor de educación de profesiones de la salud en la Escuela de Farmacia de la Universidad de Illinois en Chicago, donde vive en realidad. En 1988 y 1989 fue presidente de la Asociación Americana de Colegios de Escuelas de Farmacia, fue designado profesor invitado en la Union Medical College Hospital en Beijing, en la Universidad de Nottingham y en la University College de London. Y en 1996 fue electo para la Academia Nacional de Medicina de Estados Unidos, Academia Nacional de Ciencias. Además es miembro del Instituto de Medicina de Chicago. En 2016, por un mes, cumplió funciones como profesor invitado distinguido en la Universidad Tecnológica de Australia, donde aún continúa como colaborador, y al presente se desempeña como co-chair, como vicepresidente del panel de Ethical Guidelines for Pharmacy for the United Nations Educational, Scientific and Cultural Organization, UNESCO. Chair en bioética. Cumplió también en el año 2006, fue nombrado presidente del recién formado Comité de la Fundación Nacional de Seguridad del Paciente y copresidió el Comité de Prácticas Seguras y el Advisory Committee for Executive Leadership of the National Quality Forum. Presidió el Sentinel Event Alert Advisory Group at the Joint Commission y también se desempeñó en la Joint Commission Internacional como miembro del Comité en Directiva sobre Seguridad del Paciente. Cumplió funciones en el Comité Asesorador de Seguridad de Drogas y Manejo del Riesgo en la FDA por el término de 3 años. Y en el 2005 fue elegido como secretario profesional del Comité de Prácticas Farmacéuticas de la Federación Internacional Farmacéutica. Fue distinguido por su compañerismo por la misma institución en 2008. Cumple funciones en el proyecto de Comité de Tutorías de la Asociación de Academic Health Centers en el futuro de las profesiones de la salud. Y el doctor Manasse figura también en Who is Who in America. ¿Quién es quién en América? Who is Who in Science and Engineering. Who is Who in Medicine and Healthcare. Y Who is Who en el mundo. Bueno, comenzamos con el video. Bienvenido.
Hello to my colleagues in Buenos Aires. I'm pleased to be here with you to give you a presentation on the present and future of hospital pharmacy in the United States. I was very much honored to receive this invitation, and it is a real pleasure to be able to speak with you. Unfortunately, we are not able to be together because of the several times that I've been in Buenos Aires. I know what a beautiful city it is, and of course I've had the pleasure of meeting a number of you over the several times that I've been there. But maybe to reciprocate, I would welcome you to the city of Chicago. Chicago is also a beautiful city. It has a beautiful lakefront and many exciting things to do here in Chicago. My presentation will focus on the present situation in hospital pharmacy in the United States. We'll talk a little bit about some of the future trends and some of the directions that are being taken. And I would like to do some interpretation of some of these trends to discuss where we're heading. So fundamentally, it's important for the purpose of this lecture to understand the magnitude of the healthcare system in the United States, particularly all of its hospitals, because this, of course, has very important implications on the profession of pharmacy. When we look at the healthcare services system, there are some important things to keep in mind, and I will share these because this is unique to our country. Some of these issues might also be relevant in Argentina, but fundamentally the culture, the political environment, the demographics of a country dictate how the healthcare system is operated and what its philosophical underpinnings are. And in the United States, there is no constitutional right to health care. So this is an important point because many countries have universal healthcare systems where every citizen has a right to health care and has access to the healthcare system. This is a very politically charged issue, and what I mean by that is there are very strong opinions, both for pursuing a legal right to health care and those who oppose it. And this has been an argument that has presented itself throughout the history of the United States. And it reflects the nature of the evolution of the development of the country from its original founding in the 17th century. And it's interesting to note that in both local elections or state elections and certainly national elections, there is a lot of political debate about whether or not Americans have a right to health care. And under the current administration, there is a push to get this better defined and to institute this right to health care. Given previous administrations, this has been fought against quite difficult. It's also important to know that, and this is somewhat unique, that our healthcare system is a mix of a private system and a public system. And it's divided about 50-50 in terms of the expenditures. And what I mean by that is about 50% of the expenditures come from public funds that are administered by various government entities, and about 50% comes from the private sector. The private sector largely is employer-based healthcare insurance, and I'll get to that later, whereas the public programs, the expenditures are largely driven by several important federal programs, the first being Medicare. This is a federal program that provides for the payment of healthcare services for those who meet the requirements of age and certain conditions. This was passed in 1965, driven by some data that suggested the poor health status of the elderly. So Medicare is a very important public program. There are about 40 million elderlies that are participating in this program, and it is funded through the federal government, but individuals have contributed over their lifetime into this program's funding. Medicaid is a program for those who meet the criteria of poverty. This is a program where the federal government provides funding combined with funding from the states. And the amount of funding from the states is dependent on the proportion of their population that meets the poverty criteria. So again, there are about 70 million people enrolled in the Medicaid program. And as I said, this is a shared cost between states and the federal government. In 2012, under the administration of President Barack Obama, the Patient Protection and Affordable Care Act was passed. This is essentially a program that allows anybody to purchase health insurance. For some people, they receive a subsidy to purchase this insurance, but this was an important addition to federal support of providing access to healthcare services. Even though we have Medicare, Medicaid, and now the Patient Protection and Affordable Care Act, it's estimated that there still are about 20 million people who are not covered by any kind of insurance, and we call those the uninsured. When we look at private programs, as I said, most private insurance programs come from employer-based health insurance, and this has its history in companies providing a benefit to workers and enticing perhaps the desire for employment in a particular company because the company offers a comprehensive health insurance program. And then, of course, we have personal out-of-pocket. And this is an important issue because we like to use the phrase, there is no such thing as a free lunch. And that's true in healthcare and healthcare financing as well. So virtually all programs require a copay, which means that they have to pay a portion of the costs, or there may be what's called a deductible. So until you meet a particular financial threshold, you have to pay out of pocket. And this is highly dependent on how the health insurance is organized and how it's administered. But the most important point that I would like you to walk away with is that this is a serious, very serious political issue in the United States. Healthcare is extremely expensive, and there are many people who go into personal bankruptcy because of healthcare costs and the impact that that has on family budgets. And the lack of political consensus has many undesirable effects, both for the individual as well as for the society as a whole. And I think it will be particularly interesting to watch during the Biden administration whether or not political consensus can be developed to more formally recognize a right to health care. You may know that from a world perspective, a global perspective, the World Health Organization has passed a number of resolutions advocating for the political right to health care for all of the world's citizens. But again, in the United States, this is still in development and in discussion. We also have, of course, a substantial hospital pharmacy workforce in the United States. It's estimated that there are about 80,000 pharmacists who work in hospitals, in health systems, and several 100,000 pharmacy technicians. And of course, it's this workforce that gets the pharmacy job done in America's healthcare system. It's also important to note that in the United States, the minimal requirement for licensure and ultimately for practice is that you have to complete the Doctor of Pharmacy degree. It is the universal degree in the United States, and in terms of time, it's anywhere from 6 to 8 years of university work. Many students get a degree first, generally in a science area, and then spend 4 years at colleges of pharmacy to finish the requirements for the Doctor of Pharmacy degree. And then about 30% of the graduates actually pursue postgraduate residencies. And this is a very important extension of the Doctor of Pharmacy degree. We have seen a very substantial increase in interest in doing residencies. And part of this is driven by the increasing complexity of the nature of the work of the pharmacist and the scope of responsibility that pharmacists have in hospitals and health systems. I think it's also driven by the complexity of the science and the therapeutics of many approaches to the treatment of patients. And we have witnessed over the years great collaboration with our colleagues in medicine and nursing to assure safe therapeutics. And I'll talk about that a little bit later. But in any case, residencies are accredited by the American Society of Health System Pharmacists, and the number of residency programs and their scope continues to expand because of the increasing demand by graduates for residencies, but also the increasing demand of the skill base of pharmacists in practice. I also want to address the issue of pharmacy technicians. There are likely 600,000 to 700,000 pharmacy technicians working in various aspects of pharmacy in the United States. And while there is no universal training or educational requirement for pharmacy technicians, most states do require a certification or a mechanism for registration, because of course they have access to medicines and access to working with patients in collaboration with pharmacists. And some years ago, several of the pharmacy organizations, including the American Society of Health System Pharmacists and the American Pharmacists Association, and two of the state hospital pharmacy organizations, established the Pharmacy Technician Certification Board. This board has established standards for the requirements of competencies and skills, and over 500,000 technicians in the United States now have received certification through the Pharmacy Technician Certification. In addition to that type of certification for pharmacy technicians, we also have the Board of Pharmaceutical Specialties in the United States. That's also a collaboration of several of the national associations in pharmacy, including ASHP, and there are a number of areas that offer advanced certification and therefore giving capacity of pharmacists to call themselves specialists. And again, there is an increasing interest in becoming board certified because of the competency that such certification represents. I also want to address technology, and technology is an important component of our workforce because we have asked machines and computers to do a lot of our work, particularly around order fulfillment and patient records and IV compounding. It's very uncommon that the doctor of pharmacy level pharmacists are involved in prescription filling per se. They may supervise it, they may engage in assuring its appropriateness, but between pharmacy technicians and the technology, that is how the job of filling the orders gets done in most pharmacies and hospitals in the United States. Well, let's talk a little bit about some of the realities of the present. And I'm sure that this statement that I'm going to make now is relevant to Argentina, and that is the COVID-19 pandemic has had a very, very heavy burden on hospital pharmacy departments. As you might imagine, the patients that have arrived in both the general hospital admissions, in the emergency rooms, in the intensive care units, demand intensive management, and pharmacy has been extensively committed to assuring that patients receive kind of pharmaceutical support that's required, but also the therapeutic advice and management in collaboration with our physicians. And we have seen a number of issues that have come as a consequence of the pandemic, all the way from staffing issues, because pharmacists may have gotten sick. Some have had to quit their jobs to take care of children who are no longer in school. The workloads have gotten extremely heavy. We have had to deal with many shortages of drugs particularly the drugs that are associated with the use of ventilators, shortages of narcotics, shortages of muscular blocking agents, for example. And all of these issues, of course, fall onto the Department of Pharmacy. And as I'm hearing my colleagues today, many of them are experiencing a burnout phenomena. And I think the entire profession, quite frankly, needs a rest. And our hope is that the current vaccination programs will be successful and we'll be able to see an end to this horrible, horrible pandemic. But with that, there are opportunities that are arising from the pandemic. Certainly, pharmacists have become important resources in providing information and debating the effectiveness of certain therapeutic regimens for patients who are suffering from COVID-19. And I think the profession has also been able to develop a clarity around the competence that pharmacists can bring to these difficult therapeutic issues. I think that the pandemic has also raised a large number of public policy questions, and it ranges all the way from the requirements of vaccination in the period of pandemic and all the debate that has gone around that, to how vaccines are developed and quickly distributed throughout the country, how you develop access, particularly for those patients who are homebound or in rural communities. But there are many, many public policy issues that we will begin to debate, I believe, that have come from this pandemic and the response of the healthcare system to it. We are also seeing interesting social movements. The anti-vaccine movements, personally to me, are quite troubling, but there is strong sentiment on the part of a segment of our population about not using the vaccine. Some of it being driven by their belief that the vaccines have been approved too quickly, their safety hasn't been well established, and there are also, of course, all kinds of interesting conspiracy theories, like vaccines containing magnets and magnetizing the body. But in any case, I think that as we look at these realities, these are going to have to be taken up by the profession as time goes on. And actually, I would advise for those of you who read the American Journal of Health System Pharmacy to follow a number of these public policy and social movement issues that are included in the journal. There are also an increasing number of articles in the professional literature about various therapeutic issues, the effectiveness, for example, of ivermectin or hydroxychloroquine or other therapeutic modalities that have been suggested for which we don't have strong clinical evidence. But all of these matters, I think, will be on the profession's agenda in the United States over the next years, because the pandemic has raised questions that need to be answered, questions that need to be authoritatively reviewed, discussed, and planned. And perhaps the most important is, how does a nation as large as the United States, with 331 million people, deal with a pandemic? And how can you establish a strong relationship between government and the individuals in a country to protect the health of the entire country? I think it's also important, as we think about today, that there is this continuous evolution of science and technology and discovery. And over the course of my own career, I have witnessed a movement away, not so much away from, but Early in our professional development, we had a chemical revolution. We developed mostly organic compounds and other chemical compounds as therapeutics. And now we're moving into this biological revolution, molecular biology and genetics, and better understanding of the genes and how they're constructed and which elements of the genes direct absorption and metabolism and excretion. And that is driving more and more decision-making based on what is called personalized medicine, using the new science of pharmacogenomics to make a determination for the therapeutic development of a plan. We, of course, also have seen immense advancement in transplantation, even to a point of the development of artificial organs. This evolution has had a significant impact on the profession of pharmacy in the United States in hospitals and health systems, because there are many, many drugs that are used for pain management, for infection management, for immuno response management, etc. And as these evolutions of science and technology and discovery occur, it of course raises significant ethical and moral issues. And for example, as we are able to manipulate the genetics of a patient, there are many, many ethical and moral issues. These are not only ethical and moral issues for the profession itself, but of course for the broader society. And there will be much discussion as we have a better understanding of the genetic makeup of patients and how that might be modified around the ethics and the moral issues. I think all of this also has a dramatic impact on the scope and the role of pharmacists in hospitals. As I indicated before, pharmacists have significant responsibility not only for providing the medications, but working collaboratively with their colleagues in medicine and nursing and others to assure the safe use and the quality outcomes associated with therapeutics. And as these areas of practice expand our scope and our role, it of course provides opportunity for the enhancement in the profession and the expansion of our profession's importance. As we think about the future, I'm going to use as a framework the ASHP Foundation Pharmacy Forecast 2021, and it's titled Strategic Planning Advice. And I wanted to use this because this particular effort is a consensus development effort that the American Society of Health System Pharmacists Foundation has been involved in several years. It brings together a panel of experts from all over the country, representing hospitals of all sizes and scope. So we bring together the best minds in the United States in hospital pharmacy and health system pharmacy practice to think about certain issues. And for 2021, these strategic issues are itemized on this particular slide, and I would like to spend some time talking about this. The first being the certainty and uncertainty for a global supply chain. As we have seen the globalization of pharmaceutical manufacturing, production, distribution evolve, there have been significant issues that have been raised. So, for example, a very high proportion of pharmaceuticals that are used in the United States are manufactured in countries like China and Brazil and India. And of course, the nature of those particular countries might dictate very different practices and different ethical issues. And as a consequence, we have seen a number of challenges. So, for example, there was a fake heparin produced in China that ended up in the United States, and it ended up killing 200 people before the problem was discovered. There have also been extensive shortages of medications, primarily brought on now by the pandemic in some of these countries, but also because of other issues, perhaps, in the authorization and approval of drugs. So we really need to understand the global supply chain and how that can be made more effective, how it can be made more accountable, and how we can be assured at the local level in our respective hospitals and health systems that we have access to medicines, that the medicines meet the quality requirements, that they are properly packaged, and that there is integrity in the supply chain. And I think the strategic questions around the global supply chain need answering. Access to healthcare, as I mentioned, given the uniqueness of the lack of a legal right to healthcare in the United States, is an important question. And we have framed it from the perspective, how do we position our healthcare systems for improving access? How can we more effectively reach vulnerable populations? How can we assure more continuity of care from the time of admissions to ultimately discharge and return to home, and prevent readmissions? How can we assure that patients are getting their medicines, have access to medicines, are adhering to their therapies, and are being properly managed?
Henry, I think that you wanted to update some figures. You sent us a slide. Yes. Where I think Antonella is going to share this so you can explain the difference. Anto? ¿Qué pasó ahí?
Julia, did we lose the rest of the presentation?
Eso. There was someone with the music. Apaguen los micrófonos, por favor. Anto, ¿la podés poner en la que él quería cambiar?
Sí, es esta.
So, Henry, you wanted to talk about this slide that is new?
Yes, and forgive me for being late on this. I was waiting actually for the latest data. Oops, and I...
Por favor, quien tiene esa música, ¿la pueden sacar?
Okay, are we okay now?
Yeah.
Yeah, but I wanted to give you the latest information. And as I indicated in my presentation, it's really important to understand the magnitude of the American healthcare system. And as a consequence, that helps to define what the profession of pharmacy, particularly in hospitals, has been able to do, and what the status of hospital pharmacy is. So let's start with, first of all, the current US population is 331 million. I think Argentina is about 45 million.
Yeah, 45 million. La población argentina, me está diciendo Henry, está comparando, preguntó Argentina si tiene 45 millones de habitantes, aproximadamente es ese número. Yeah,
we have in the United States about a little over 6,000 hospitals, of which about 1,800 are in rural areas. So we have many areas of the United States that are extremely remote, and we have to give special consideration to healthcare services in those areas. So about 6,000 hospitals. We have just a little under 1 million beds in the US. And this is interesting because I can remember a time when we had almost 5 million beds, but we have seen each year a decrease in the number of beds. And that is largely as a consequence of more and more procedures that are able to be done outside of the hospital on an ambulatory care basis. The expansion of what we call urgent care centers, where you can get immediate care without going to an emergency room. But in any case, this has been a continuous slow downward trend. But even so, we still have about 1 million beds, and it'll be interesting to see where this goes in the future. Of those 1 million beds, we have about 70,000 intensive care beds. And
Henry, just a moment, I'm going to translate a little bit. Lo que está diciendo Henry del número de hospitales y 6.000 y 1.800 que están muy alejados en lugares como remotos, y eso es un problema para ellos. El número de camas en realidad les va disminuyendo porque, bueno, cada vez hay más procedimientos, todo, pero aproximadamente son 1 millón. Esto les estoy resumiendo de los datos que le está dando. Yes, Henry, I'm going to interrupt you sometimes to translate what you say.
Yeah, so, no problem. And I just want to comment that this issue of intensive care beds has, of course, become a very serious policy question in this COVID pandemic. And we are actually now experiencing a resurgence of the necessity for the use of intensive care beds. And some areas of the country are experiencing shortages.
Bueno, el problema fue con las camas de terapia intensiva. Bueno, como pasó en todas partes, se quedaron muy cortos con el tema de la pandemia. Y bueno, recién ahora quizás se están más o menos equiparando, pero en muchas partes estuvo como problemático la falta de camas. Yes, Henry, thank you.
Then in terms of the admissions, we have about a little over 36 million admissions. So with these almost 1 million beds, about 36 million admissions. The average length of stay in the US is less than 5 days. It's 4.2 days, something like this. And there's very strong pressure to get patients in and out of the hospital as quickly as possible.
Bueno, lo que nos dice es que tiene ingresos anuales en el hospital, internaciones anuales, 36 millones. Y que el problema al haber 1 millón de camas es que hay una gran presión para dar de alta a los pacientes y que en promedio quedan internados 5 días.
And then in terms of the economics of healthcare, we spent last year $1.1 trillion US for expenses for all hospitals. And that's about 25% of the total cost of healthcare in the US. In contrast to Argentina, I just read today that Argentina spends about 9% of its gross domestic product on healthcare. The United States spends about 18%, so 2 times as much as Argentina on healthcare.
Sorry, I'm going
Yeah,
to translate. Comparando, bueno, dice que esto es lo que se gasta, 1 trillones, ellos tienen distinto porque el 1.000 millón no existe, lo llaman directamente billones, así que hay que escribir los ceros y sacar, pero bueno, es un montón, y que ellos gastan aproximadamente el 18% del PBI en comparación con el leyó un trabajo de Argentina que gasta el 9%. Yes, Henry.
And then as a proportion of the total spending in hospitals, about 10% of the expenditure is for drugs. So in 2020 in the United States, that amounted to about $535 billion. This is an extensive amount, and I think it says something about the intensity of drug use in the American health system. So I wanted to share these with you because over the years, as the care has become more complex, as we have tried to get patients out of the hospital quickly, as we have had a focus on patient safety and quality, these have all been important developments for the advancement of hospital pharmacy practice.
I'm sorry, I have a problem with my computer. I was solving it. Bueno, en realidad lo que dijo Henry, digamos, de lo más importante, que todo es importante, pero esto es lo que en medicamentos de todos sus gastos es el 10%. Y él quería, bueno, mostrar esto ahora como actualizando datos. Henry, we are going to questions now.
Okay.
We have some. Bueno. Wait, please, that I don't know if you can read them, but
well, I saw some while the lecture was going. There were several questions. One relating to pharmacy technicians, and
yeah, that one was. One is Antonella. Antonella, can you read it? How that's the relationship between the School of Pharmacy and professional work? Do the pharmacy students in the last years attend classes in any hospital? ¿Cómo es la relación entre la Facultad de Farmacia y el trabajo profesional? Los estudiantes de farmacia en los últimos años van a tomar las clases en los hospitales.
Okay. So in the last year of the pharmacy studies, the students only do what we call clinical rotations, which means that for a period of about 6 weeks, they will be under the supervision of a preceptor pharmacy faculty member in a different institution, and they will be introduced not only to the nature of the practice in that assignment, but more importantly, they are required to be participating members in the pharmacy services provision, so that, for example, if you are assigned for 6 weeks in a transplant unit with the pharmacy faculty who are responsible in that unit, you will be involved in patient care rounds. You'll be involved in post-mortem discussions. You'll be involved in all the decisions in the management of that patient. And you are expected as a student to be able to contribute to the discussions so that you you learn how to become an active participant in the care of the patient.
Con respecto a esto, él dice que los estudiantes rotan por algún sector del hospital por 6 semanas con un miembro de la facultad y van a un determinado sector. Por ejemplo, si van a trasplante, van a estar incluidos en las discusiones con respecto a las drogas, a lo que se necesite, bueno, a todo lo que corresponda a ese sector, y se espera que el estudiante sea capaz de contribuir en estas discusiones y charlas.
I would also add, Julia, that for that entire year, they have different experiences. So some will be in the hospital, some will be in the community pharmacy, some will be in the industry, some will be with the government. And then we also allow students to do what we call non-traditional clinical experience. So, for example, I always had students coming to ASHP to look at the work of a national association. And so that last year is a very important educational requirement, because it doesn't only sharpen their technical and scientific clinical skills, but I think it also socializes them for the attitudes and the culture of healthcare and how you behave in that system.
Él dice que hacen rotaciones por diferentes sectores, porque puede ser el hospital, puede ser la farmacia comunitaria, puede ser la industria, y también él quiere que vayan a lugares no específicamente, digamos, de atención, como es el caso de ir a la Asociación de Farmacéuticos de Hospital, digamos, la antigua de Healthcare System, para que vean cómo es una institución nacional que se ocupa de los farmacéuticos. Y lo que les interesa, lo que le interesa más que nada, es que como que tomen la relación con la gente, que aprendan a manejarse en esa área, ¿no? Como a tener como más trato con la gente que los recibe, ¿no? Y acostumbrarse. Ok, Henry. I'm looking, that was my question. Is the Board of Technicians accreditation composed of pharmacists? And have you ever had problems with the demand of them, of technologies, technicians auto-checking? Lo que le pregunté es si el board de technicians, quienes los acreditan, está formado solo por farmacéuticos, y si alguna vez tuvieron algún tema de requerimiento de los técnicos de autosupervisión, de no estar supervisados por farmacéuticos.
So let's first talk about the governance of the Board of Pharmacy Technicians. It is made up of the American Society of Health System Pharmacists, the American Pharmacists Association, and the National Association of Boards of Pharmacy. Those are the licensing boards of the individual states. Then there are 2 state associations, Michigan and Illinois, who helped establish the board many years ago. So the governance is all by pharmacists who are the chief executive officers of these national and state associations. So it's a very high level governance structure. They have developed a board certification examination, and it's that examination, when the technicians complete them and pass them, that allow them to use the terminology certified pharmacy technician. Now, that board does not get involved in issues of scope of practice. That's governed largely by the state governments and the local hospital. So a number of hospitals have developed what we call check, tech, meaning that technicians can, in fact, check other technicians, the work of technicians. And as I mentioned in my talk, very little of the prescription filling and the processing of orders is done by pharmacists. It's mostly done by automation and by pharmacy technicians. So the deployment of pharmacy technicians is a judgment that is made by the pharmacy director, and that's driven by their own trust in the capabilities and skills of that technician.
Bueno, con respecto a la certificación de los técnicos, los entes que lo dan están formados por farmacéuticos y son 3 instituciones nacionales y hay 2 instituciones locales. En Michigan creo que dijo, ayúdenme chicas, y en Illinois. Los técnicos tienen, para ser acreditados, tienen digamos que tienen una exigencia importante y, como dijo él en su charla, con respecto a la preparación de lo que nosotros diríamos pedidos de sala, digamos, de medicación, no intervienen los farmacéuticos, sino que lo hacen los técnicos. Y en cuanto a la supervisión, hay técnicos supervisados por otros técnicos, pero también depende mucho del hospital en que esté y la confianza que pueda tener el jefe de farmacia en estos técnicos. Y hay que tener en cuenta que también ellos tienen mucho automatizado, digamos, como casi todo automatizado. Ok, Henry. That's another question regarding COVID, pandemic, and anti-vaxxers. Was it harder for pharmacists to approach people as effective communicators, or did people tend to seek professional advice more than the usual? Con respecto a la pandemia y los antivacunas, fue más difícil para los farmacéuticos acercarse a la gente como comunicadores efectivos, o la gente prefirió buscar consejo profesional más que antes, digamos, más que lo usual.
Yeah, so let me start by saying that the health authorities in the US are estimating that there are about 91 million people who are still unvaccinated in the US. So think again about 331 million people in the population. A portion of those are children that are not eligible for vaccinations. But 91%. So the national vaccination rate is a little over 50%. And this is troubling, of course, to those of us who know epidemiology, because we need 70 to 80% of the population to be immunized in order to achieve herd immunity. So the question is what to do with these 91 million people. And there's a very broad range of viewpoints in this population, and they range from, as I mentioned earlier, conspiracy theories of all kinds and what I would call just crazy ideas, all the way to people who feel that the vaccine may not be safe, that it moved through the approval process very quickly, and maybe corners were cut, or that the vaccine is not fully approved and therefore they don't want to use it. And it's the patients who are in this realm of personal safety concerns where I think pharmacists could have a discussion. And
Henry,
actually,
I'm going,
yeah, go
if you
ahead.
don't mind, I translate. Bueno, en Estados Unidos tienen un 50% de vacunados y le falta para el 70%, 80% que se requiere para la inmunidad de rebaño. Tienen una gran parte de, no solamente antivacunas, tienen gente con ideas conspiranoicas, pero aparte de todo hay gente que no tiene confianza, como sea que no hay mucho publicado, no se sabe mucho sobre seguridad y tienen miedo de ser vacunados. Thank you, Henry.
Yeah. I see another question here talking about drug shortages, and that is also a problem in Argentina, but also a question about people who do not have coverage, how they get treated. How do they treat the patients with COVID? What is public policy? Yeah, so you want me to answer that question?
Which is the question? I'm looking
It's
down.
A question from Claudia Correa.
Justo arriba está Julia, la que él leyó.
A ver, Mari, ¿vos la ves? ¿La querés traducir?
Sí, de Claudia Correa, que
ayuda.
pregunta si hay problemas con las coberturas sociales, cómo se tratan los pacientes con COVID y si son de políticas públicas estos temas.
So let me start by answering the last question. What is a public policy? A public policy basically is a political choice of a decision on how to implement a particular action. So what I mean by that is that if a person does not have insurance, if a person is not covered by Medicaid, they have no money, how do we deal with these people when they show up in the emergency room? Well, because we don't have these issues resolved, we have this patchwork of laws that try to fix these kinds of issues. And that's a representation of public policy. So the policy is, well, we cannot turn away anybody who shows up at the emergency room. We have to take care of them. So the public policy became a law that requires you to stabilize the patient and to make sure that the patient can be discharged. Now, then you say, well, who pays for that? Well, the payment for that comes from the funds, the earnings of the hospital. So there are some hospitals in certain locations that have very large expenses, debts that they incur because they take care of so many people. So a university, for example, it doesn't have a mechanism for raising money. So university hospitals that I was involved in my career, I would need to go to the legislature to fill the hole that was created by this uncompensated care. Do you understand?
Yeah. Bueno, lo que dijo Henry es que, bueno, que lo que tiene que lograr el paciente es que el paciente, si aparece en la emergencia, es cubrirlo totalmente. Henry, can you repeat the coverage, the money, what you say about who pays?
This would be the uncompensated care. Uncompensated meaning that no one paid.
Nadie lo paga, así que esto, digamos, es un tema, pero bueno, saben que se tiene que ocupar de la persona ni bien llega a la emergencia y hasta que se cure lo tienen que hacer. And if it is uncompensating, nobody pays, is the hospital taking over these expenses?
Yeah, and this is a really interesting issue. It gets a little bit complicated. So let me try to explain it. So hospitals typically are organized as not-for-profit organizations, not-for-profit. So they're different than a pharmaceutical company who is established to make profits. So as a not-for-profit organization, you don't have to pay taxes. So most hospitals that are organized as not-for-profit organizations do not pay taxes.
Los hospitales, sorry, Henry, los hospitales son sin fines de lucro y bajo esa denominación no pagan impuestos. Las organizaciones que son sin fines de lucro no pagan impuestos.
So hospitals that earn money, make profits, they are required by law to demonstrate community donations, community impact. So what the hospitals will do is they will use that profit to cover the uncompensated care. Now that would be applicable only if a hospital is making a profit. So you met Rita Shane some years ago. She works for Cedars-Sinai Hospital in California, Los Angeles. It's a very rich hospital. They make a lot of money, but they have to do a lot of community development because they're not in the business of making profits. Then in addition to that, there are many both governmental organizations as well as private organizations. Some are church related, some are philanthropic related, that provide clinical services in impoverished communities. So my wife, for example, that she spent her entire career in impoverished communities in Chicago. And that money comes from donations, it comes from foundations. So you could say maybe 20% of that population who doesn't have coverage, they're not left alone. On the other hand, it's very difficult for the dignity of an individual not to have money and to need care. This is a very complicated problem.
Si bien estos hospitales que están inscriptos bajo esa forma, los hospitales hacen dinero, entonces, y tienen ganancias. Entonces, lo que tienen que hacer para seguir bajo esto, los non-profit, como él nombró antes, lo que tienen que hacer es atender a gente que lo necesita. En relación a sus ganancias. Y también lo que hay son muchas organizaciones, fundaciones que dan dinero para estos trabajos comunitarios, como por ejemplo la esposa de él que trabaja para un grupo, digamos, para sectores pobres de Chicago. Y así es como es atendida la gente en el caso de COVID que no puede pagar. Aparte, lo que él dice que es muy duro para una persona decir, bueno, no tengo dinero y necesito que me atiendan, pero no tengo dinero para pagar. Ok, Henry. I'm looking. Mariana, ¿alguna otra pregunta que vos veas? Porque me perdí.
Creo acá hay una última que puso Antonella sobre que Henry es vicepresidente de un panel de como recomendaciones de guías de práctica de clínica con respecto a lo que es la ética y que es un punto importante en nuestra profesión y nosotros no tenemos bioética en el plan, digamos, de la carrera, cómo se podría esto solucionar, me parece, si en América es diferente la inclusión de este subject, de esta materia.
¿La vas a traducir?
Yeah.
Creo que Henry la puede leer. I think that Henry can read it in English in the...
It's in English,
chat.
okay.
Yeah. I think it's important here maybe to look at language. This word specialization, I think in Argentina, has focused on sites of practice. So practice of pharmacy in the community, practice of pharmacy in the industry, practice of pharmacy in the hospital. And I understand there was very important rationale behind that designation because it had to do with funding and educational requirements and those kinds of things. We use specialization in a different way, so a different interpretation of the same word. We don't focus on sites of practice. We focus on areas of expertise and competence in the patient care. So the biggest specialization is in pharmacotherapeutics. So you can take an advanced examination in pharmacotherapeutics, and if you pass, then you are board certified in pharmacotherapeutics. That's a very high level understanding of drugs and their actions and the use in patients and all of that. There are, I believe now, 12 of these specializations. And pharmacotherapy is one, oncology is one, psychiatry is another, transplantation. If you go to the website for the Board of Pharmaceutical Specialties, you can see each of these specializations and the requirements. So that it's a different way of looking at specialization. So I'll make one other point. I think as a policy for the profession, we have identified a very specific process for identifying a specialty, because not everything is a specialty, right? So there is a extensive process that deliberates whether or not a particular area should be designated as a specialty. And if it is designated as a specialty, then you can develop ways of assessing the competence of an individual in the specialty. So in many regards, this is quite similar to what we do in medicine for physicians.
Lo que él dice es que ellos tienen varias especialidades, se orientan hacia lo que es, digamos, la atención del paciente, terapia, digamos, como terapia clínica, ayúdame Mariana.
Oncología, psiquiatría, nombró varias áreas que se pueden ver de los distintos, el board sería como un comité al que se puede acceder. En realidad creo que la intención de lo que nos está diciendo Henry es que no todo es una especialidad y que las áreas de especialización deberían ser similares a lo que hacen los médicos, ¿no? Me parece que esa sería la idea.
¿Qué es una especialidad? Él lo que dice es, primero discutamos qué es una especialidad, después vemos cómo lo armamos y cómo la gente, digamos, es especialista. Esto es lo que,
claro,
lo último
cómo acceder
que dijo.
a ese, qué requisitos deberíamos considerar para acceder a una especialidad que, bueno, que valiera la pena, ¿no? Porque no todo es especialidad. Eso es lo que yo entendí de lo que explicó.
Bueno, creo que esto también contestó la pregunta de Gaby Molina, que preguntaba sobre las especialidades. Y ahora creo que Matías Quiroga, que lo habíamos salteado, perdón, dice... Yo había preguntado hace un rato cómo habían hecho en su país para hacer que los farmacéuticos se involucren con el hospital, comparado con otras salidas laborales, apuntando al bajo porcentaje de farmacéuticos hospitalarios que nosotros tenemos. Henry, how have you done in the States for getting the pharmacists, for making the pharmacists get involved in the hospital pharmacy, compared with another, for example, community pharmacies or industry, because it's a big number of pharmacists in the hospital. How have you made us get involved the pharmacists in the hospital pharmacy?
Yeah. Well, you know, hospital pharmacy has evolved in fascinating ways in the United States. And I think it's been because of the work of the universities, because of the work of the national associations, and sometimes government policy. So a big boost occurred in 1965 when these two big government programs started, Medicare and Medicaid. At the same time, there was a lot of concern about the quality and the standards associated with sterile products because they were being manufactured in the hospitals. And there was also concern about the cost of medicines, the use of medicines. And I think through all of these evolutions, pharmacy leadership has always come forward with ideas about how pharmacists can be most effectively used in the hospital. And I have to say, you know, I'm at an age now where some of my classmates were these early pioneers who were advocating for clinical pharmacy, a more clinical role for the pharmacist. And I know in my own university, we experimented working with our doctors in pediatrics and psychiatry, areas where medication use is very problematic. And we began to demonstrate that what we learned in school was different than what doctors were learning in school. And the combined expertise allowed for better decisions. And we published papers about these things. We use the papers to advocate in various segments. And I would say today, when I go to a hospital pharmacy department, I don't recognize pharmacy because it is so different than what it was when I was a young person. And I really attribute that advancement to the leadership of the profession and its capacity to make good arguments and to lay out the cases and to demonstrate the utility of the pharmacist. So I was just reviewing in preparation for today, about 25% of the pharmacists in the US work in hospitals. So it's about 80, 90,000 people. They have very good jobs. They get very good pay. They have tremendous influence on decision-making. And when you speak to hospital administrators or physicians or nurse leaders, they're always very, very positive about the contribution of pharmacists. So this is a long journey.
Lo que dice Henry es que él, digamos que y su grupo de compañeros fue de los pioneros que demostraron que podían ser de ayuda importante como farmacéuticos en los hospitales. Hoy día es el 25% de los farmacéuticos va a trabajar a los hospitales, pero claro, están muy bien pagos y están muy bien considerados, y han demostrado que, digamos, en las épocas que comenzaron, que el farmacéutico tenía un punto de vista o un estudio original diferente que el médico con respecto al medicamento. Entonces ellos lograron demostrar la importancia del farmacéutico. Y también lo que para ellos, digamos, otra cosa que los ayudó es la creación del Medicare y del Medicare por los años 65, donde, digamos, que decir que desde el gobierno ya había regulaciones como para que los farmacéuticos entren a trabajar a los hospitales. Pero fue del farmacéutico demostrar que estaba capacitado y podía dar, digamos, como una ayuda importantísima en el grupo, con los médicos, con las enfermeras, con todos. Así que dice, bueno, que es un largo camino. Marcela is in the auditory, has how is participation of hospital pharmacists in health technology assessment, especially in COVID pandemia? Bueno, ¿cómo es la participación? No sé, Marcela, si voy a traducir la participación de los farmacéuticos de hospital en el asesoramiento de de tecnología en salud, especialmente en la pandemia.
And let me say, Julia, at this point, this is going to need to be my last response,
Okay.
because my boss is waiting for me to go to dinner.
Okay, yes, yes.
And you know, we eat dinner at 6 o'clock.
Yes. Ellos cenan temprano a las 6, así que va a ser su última pregunta.
But you know, let's talk. This is a very important question. What's the role of the pharmacist in assessing the various treatment options for the care of COVID patients? That's what I understood. Have I got that correct?
Marcela, ¿querés liberar tu micrófono y completar, o no sé, ¿estás ahí?
Sí, gracias. La hago en castellano, perdón. Gracias.
Yeah.
Quería
Hello,
saber,
Marcela.
Hello, Henry. Nice to see you. La participación de los farmacéuticos en los equipos de evaluación de tecnologías sanitarias que hay ahora, donde está liderado por médicos, y veo que hay incipiente participación de farmacéuticos. ¿Me ayudas, Julia, por favor?
Sí, Marce. The pharmacists in evaluation of health technologies, that now there are here there are more physicians, more doctors, and that evaluation of health technologies.
Yeah, and I'm maybe, in order to respond to the question, I'm going to look at pharmaceutical agents, drugs, as technologies in healthcare, right? They are high tech. You know, even though they're little pills or little capsules, we know that they're very sophisticated medical components. I would say the pharmacist's significant role is generally at the level of the formulary. So every hospital has created a formulary, and decisions are made collaboratively between physicians and pharmacists about which drugs will be used in that hospital. So that's, I think, the first decision. And that is not a simple decision, because from a clinical point of view, particularly in some drug categories, it's very difficult to distinguish between one and the other in terms of their therapeutic effect. So with COVID, all of a sudden, we're throwing out antibodies, we're throwing out remdesivir, we're throwing out hydroxychloroquine, suggesting ivermectin. And in all of these areas, pharmacy has had to do an extensive review of the global literature, as well as global research that's been ongoing or is moving in these areas. So, for example, I think generally we would conclude that ivermectin is not effective, so it shouldn't be on the formulary. I think, quite frankly, there's still a lot of questions about the monoclonal antibodies and when to administer monoclonal antibodies. There's still some question about dexamethasone and the use of steroids. So these are all, I think, important technical, clinical questions that pharmacy has to participate. You know, we need to be part of that decision-making, because we want the best outcome for the patient.
Lo que Henry dice es que, bueno, el farmacéutico importantísimo para elaborar el formulario de drogas que tienen en el hospital, digamos, el vademecum sería drogas, y que, por ejemplo, buscar información sobre, hablando de la pandemia, sobre la utilidad de la ivermectina, que ahora saben, bueno, dicen que no es efectiva, anticuerpos monoclonales, dexametasona, digamos, todo lo que surgió como drogas en el tratamiento de COVID. El farmacéutico tiene un rol importante en el hospital. Well, yo lo voy a despedir a Henri. Henri, thank you so much for being here. We hope you can come someday and bring Arlene. Le estoy diciendo que esperamos tenerlo, traer a su esposa, porque las veces que vino, que fue invitado por la Asociación la Asociación Argentina de Farmacéuticos de Hospital, Marcela me lo presentó y yo lo conocí a través de ella. Vino solo, vino una vez con el hermano, with your brother, you came, not with your wife. Así que queremos tenerlo. Le voy a agradecer. Thank you, Henri, very, very much. Always very interesting. We had some other questions I had in mind, but you have to go to dinner.
Yeah, and unfortunately, there's no tango.
No tango here. No tango there in Texas.
Hello, Anna.
Thank you very much, Henri.
Yeah, thank you, and let's stay in touch.
Yes, of
Julia,
course.
give my regards to your family.
Yeah, thank you. A big kiss to Arlene and the kids. So goodbye, Henri.
Bye-bye.
Bueno, yo les agradezco a todos los que están, les pido disculpas a veces por la traducción, hace mucho que no tengo, no hablo inglés, no tengo con quién practicar, entonces algunas cosas las quería yo, me da no sé qué interrumpirlo, pero quería de alguna manera tener en mente todo lo que tenía. Así que gracias a todos ustedes.
Directiva y desde el Comité Científico de AFAM te recontra agradecemos tu participación.
Gracias a ustedes por la invitación.
Excelente la charla y queda grabada en el canal de YouTube de la asociación, así que los invitamos a que puedan escucharla y podemos seguir haciendo preguntas al respecto. Bueno, muchas gracias a todos, buenas noches.
Bueno, chao. Chao a todos.